Thank you very much for that kind introduction, and what an honor it is for me to have the chance to address you as members of the American Hospital Association. This membership, 5,000 hospital and healthcare provider institutions strong, 37,000 individual members, represents in a very fundamental way a backbone of care delivery across our country. Even today, while we contemplate whether this swine flu thing might be something to be concerned about, we're very pleased about the presence across our country of first-class health care that you make available, and appreciate you in every way. Through your association efforts, you're also an extremely important part of the policy dialogue taking place in this town. And as we'll be discussing this morning, health care reform front and center. Never more a timely moment for you to be with us in Washington, but your association continues very effectively your efforts every day. Well, you might know I'm kind of a last-minute fill-in. Chairman Stark battling a very bad cold, unable to be here, and I'm pleased to be here. When I got the call, they said, well, and you'll be following Eric Cantor and Senator Lindsey Graham. I said, Cantor and Graham? Well, those are the two of the smartest, most articulate members of Congress. Why are you asking me? And they said, well, you represent something very different. So for whatever, I'm pleased to do my part. Just back from fighting floods in Fargo, North Dakota. In fact, we had disasters all across North Dakota. 80,000, maybe 100,000 people ultimately volunteered in that Fargo flood fight, which successfully turned back the surging Red River. Now that is participating in a fight like that is the ultimate in a democratic small d experience. I was at Sandbag Central late one night, and true story, on the one side of me was a neurosurgeon. On the other side of me, a prisoner from the Cass County Jail. Later, I was recounting this to the Adjutant General, who observed, well, at least one of the three of you is trustworthy. Who do you mean? Who do he mean? Well, I want to talk this morning reflect about the first 100 days of this administration, because I believe a reflection on the first 100 days gives us notions of what's to come, particularly in health care reform. And then I want to talk about the prospects of health care reform, the process, the provisions of health reform that are under discussion, and its ultimate prospects. Well, I think looking at the first 100 days of this new administration, you'd have to conclude a couple of things. First, there is a significant change in direction in this country, and secondly, that the American people are responding favorably. First, as to significant change. It's pretty clear we have a direct, tough-minded president who does not shy from an aggressive assertion of federal resources and federal leadership in addressing problems. Just take, for example, the economy. So far, passed a stimulus, $789 billion stimulus package. Taken aggressive action on housing markets, aggressive action on credit markets, provided some very tough medicine for Detroit, and is developing regulatory reforms that include a very direct discussion of compensation occurring on Wall Street. The healthcare areas, almost lost in all of this, have been extremely significant. In fact, within the first 100 days, I think you could say that at least in 3 areas, we've moved more health policy than occurred not just in the last Congress, but maybe in the last 2 or 3. First, S-CHIP, second bill signed into law by this new administration, a bill that had been tied up and vetoed not just once but twice, and really had stalled out for some considerable period of time. Just like that, reauthorized through fiscal year 2013 with the coverage for 7 million extended and another 4 million children added to the mix. 11 million children now brought under S-CHIP coverage and secure, authorized, and provided for the next several years. Two other major health issues addressed in the stimulus bill, each extremely important. The first, HIT, $19 billion, to advance a goal that has long been held by members of both political parties, developing an interoperable electronic infrastructure for health care. You know, in the financial sector, the average computer or IT investment per employee is something like $10,000. In health care, about $500. Now, admittedly, the sectors are very fundamentally different, but I think it's pretty clear we have lagged beyond the promise of substantially improving health IT infrastructure on medicine. It is estimated that the provisions of the health IT component, with its grants and reimbursements incentives, hospitals and doctors, will bring 70% of hospitals, 90% of doctors into compliance with modern interoperable health IT standards. I think it's very interesting that the Congressional Budget Office, as it looked at health IT, didn't just look at the $19 billion cost. They ascribed to this level of implementation of health IT a $12 billion savings, as unnecessary, duplicative, redundant, and even harmful procedures are identified and eliminated, and best practices elevated through the practice of medicine in our country. Many of you will have made extraordinary investments in health IT. It would be my hope and belief that you'll be able to recoup some of that investment with the reimbursements flowing under this program. The third major health issue advanced so far is identifying the reality of what a recession does to health care. An economist told me earlier this year, you know, all of this would be fascinating to watch if it wasn't actually happening. I'm telling you, this recession has had one interesting but interrelated dynamic after another. Rising unemployment means rising uninsurance. Rising uninsured numbers mean higher unpaid costs for our hospitals. It means that state Medicaid rolls strain just at the time state revenues drop. It is the worst of cascading circumstances relative to health care reimbursement. And so $87 billion in this stimulus package to address the health care concerns during this economic downturn were incredibly important. The FMAP equalization, 6.2% for all states, and then more for states that are experiencing higher unemployment levels, are going to provide an extraordinary level of relief, not just to state governments, but I believe to healthcare providers, including hospitals, who otherwise would have faced deep Medicaid cuts at the time you could least afford them. Also, additional temporary enhancements on dish payments for 2009 and 2010, reflecting, I think, again, the higher numbers of uninsured in this economic crisis. Well, so it's been a very active 100-day period by any measure. What's the American public think? It's pretty dramatic, really. We have gone, the most recent polls released last week show that an Associated Press poll, 48% of the American people believe we're on the right track, 44% wrong track. But the right track number is up 31 points since October. And if that's an unfair point of comparison, because that was about as bad as it got, it's up 8 points from February. And so I think you can conclude that the American public is looking at a strong president with an active agenda, moving things forward, and even in a time of economic uncertainty, we've slipped to more in the right track versus wrong track for the first time in several years. The conclusion for health reform and other major legislative initiatives of this administration is that he's come through this initial period, got his administration stood up, initiated, again, strong initial proposals, and still has his political capital very much intact to apply to the longer range goals ahead. Making this perhaps an even more opportune environment for health reform will be something that Congress does this week, House and Senate, as we address the conference report on the budget. Health reform will be provided as something that might be dealt with by budget reconciliation. What that would mean in the Senate is a 51-vote majority, not a 60-vote requirement to break a filibuster. It would be my hope that this provision of the budget would never be called upon, that you would not do health reform through budget reconciliation. But it is certainly a signal to both parties that just say no is not a position when it comes to this health reform debate. We need health reform. We need it worse than ever. The moment is ripe. And an enduring health reform will involve both parties in crafting the final legislation. I believe health reform has been identified as a central issue for a number of reasons. First, the Democrat core value principle at 45 million uninsured people really is an unacceptable, raises unacceptable questions about equality of care provided across our great country. But additionally, there are profound long-term consequences for the economy and the federal budgets if we just let things continue to go as they have been. In 2007, we spent $2.2 trillion on health care, 16.2% of GDP. Now, that's $7,400 per person, 300% more than when I was an insurance commissioner back in North Dakota in 1990. The prospects of no action means we're 25% of GDP in health care by 2025, 49% by 2082. I mean, clearly that can't be sustainable. A McKinsey study compared to Western Europe finds $450 billion in excess spending each year. And what are we getting for it? We rank 48th. Americans rank 48th in longevity obtained, just after Jordan and Bosnia. We have 1 in 6 that are uninsured, and it is estimated that more die as a direct result of not being insured than die in homicides every year in this country. Now, a compelling demonstration of proof of the inefficiency in our present health care system is found in the differentiation of medical care expenses paid by Medicare, as measured in the decedent's last period of life. Back our way, we think of Mayo Clinic in Rochester, Minnesota as the gold standard in care delivery. But do you know there is an institution in New York City that is 350% greater cost than Mayo Clinic in measuring an equivalent point of time at that end-of-life stage, 350% variance, and that can be found in many different areas relative to differentiation in care. Recent data also reveals something about this differentiation in cost. It is not producing quality. In fact, the Medicare matrix actually shows, in fairly compelling ways, I believe, representing a lower cost region of the country, that lower cost is resulting in higher care, and some of the higher cost areas in the country are providing lower care. Well, this combination of circumstance has this issue completely at the forefront of what this president wants to achieve in this first Congress of his first term. And the legislative process is structured, I think, to treat it as the highest priority, again, linked directly with dealing with the economy. Going in, you will note an approach fundamentally different from what was attempted in the Clinton years, and reflects some real wisdom that's acquired through the School of Hard Knocks. It is wise to let those who enact the legislation have something to do with writing the legislation. The Clinton proposal, you will remember, was a package delivered from the White House. We were simply supposed to enact it. It was written by a bunch of whiz kids and had a political half-life of about half a second. This time it's different. The president, as you heard yesterday through Nancy DeParlo, has outlined principles, and the enacting is left to Congress. Now, on the House side, that has involved absolute buy-in by the Speaker, Nancy Pelosi, who has demonstrated herself to be a very determined and forceful leader of the House of Representatives. She has assigned 3 committees of jurisdiction, Ways and Means, Energy and Commerce, and Education and Labor, to work collectively, not 3 different bubbles, 3 different kettles cooking this thing, but a collaborative effort across the lines of jurisdiction, producing a product that would come to the House in July for enactment or for passage out of the House by the August recess. The timeline in the Senate, also very aggressive. In fact, you've had the 2 committees of jurisdiction, the Senate Finance Committee and the Help Committee, chaired by Senator Kennedy, announce bills by June. Now, we on the House side take these projections kind of lightly when it comes to Senate projections of timely action. But one thing is clear. They are also set on an enactment or a passage in the Senate by that August timeframe. The coordination seems to be a little less clear in the Senate between the 2 committees. Senator Baucus, as you know, in December put out a comprehensive and substantive outline of what would be components to be considered by the Senate Finance Committee. He is now refining those in discussions with stakeholders. And the Help Committee, chaired by Senator Kennedy, has its own very compelling dynamic. Many of us believe that Senator Kennedy views this as the signal achievement that he might accomplish in his Senate career, and is going to be a force to be reckoned with. All the moral authority of all his years as it comes to finding the votes to pass this package. I believe he's going to be an extremely important player in this package. And again, the budget reconciliation element here will have an impact in terms of the dynamics unfolding. Well, what are the reforms under discussion? You've been studying these, I know, but let me just quickly recount them. Universal coverage. Within the House Ways and Means Health Subcommittee, we are looking at, that means employer provide or employers pay into a fund that does subsidize individual purchase of coverage, so employer pay or play, and an individual mandate. Now, President Obama did not campaign on the notion of an individual mandate, but seems to send signals that an individual mandate would be acceptable provided there are sufficient subsidies so that the premiums would be affordable under that provision. Another major thrust of health reform, access to insurance guaranteed. I'm the only former insurance commissioner in the House of Representatives, and these issues have long been talked about: guaranteed issue, community rating, and some kind of minimum coverage standard that reflecting about the average of the health insurance policies out there to date. An important feature of House legislation is the insurance exchange option. What this would provide would be insurance opportunities where an individual employer could have his employees, rather than just select a single policy provided by the employer, shop within the exchange from a variety of competitive options. And what is emerging as a very controversial element of early House considerations, a public plan option within the options in the insurance exchange. So you could pick something from the Blues, you could pick something from Aetna, or you could pick something like the federal employees have, ultimately underwritten by a new government entity providing that coverage. Also an important area of discussion, delivery system reforms, with bundled reimbursement ideas to address care delivery fragmentation, notions you've, again, been hearing about, and much work needs to be done to refine exactly how these would apply, whether they're pilot status or more broadly implemented in reimbursement reforms. Medical home, accountable care organizations seeking greater integration between physicians and hospitals, bundling of post-acute care, or and trying to get at this notion that frequent readmits have become a significant cost component in Medicare, some kind of issue to either penalize readmission or bundle post-acute post-acute care to cut down on that post-discharge readmission event. Medicare reforms would also be part of the package. And the CHAMP Act last year advanced a few of them. You could look at ideas still percolating around that were not enacted: greater insurance coverage for preventive measures and increased help for low-income seniors to be part of a package. Now, where discussions on health reform have advanced less fully is in how we pay for it. The difficulty of this is going to be extraordinary and is going to, I believe, test all of us in terms of whether we can conclude a package or not. I put this one in the area of low-hanging fruit. Medicare Advantage plans take federal taxpayer dollars out of the Medicare system, put them into basically increased reimbursement for health insurers. We think Medicare costs ought to go for medical care, not insurance services. And so something that costs $1.12, $1.20 to administer $1's worth of services, we think simply does not make sense in this environment. The cost savings from that are part of the financing package. Now, additionally, it gets harder. The President's budget recommended that for those over $250,000, there would be a change in the deductible percentage of charitable contributions, for an example. Already you've heard howls of protest from members of both parties on that one. And so the pay-fors are going to be extremely difficult, and I would say there is no clear outline yet. Let me just conclude with a story that kind of relates a little bit to cost and a little bit to Washington, and it came crushingly to mind as I was stuck in traffic trying to get over here from Capitol Hill. You know, I'm so proud to come from a state that in its history has never had a traffic jam. But honest to God, every day it's traffic, traffic, traffic. My first term, I got to the airport with just minutes before the flight, and at the airport there was a traffic jam. Just a Gordian knot of travel, traffic, just inching along. This was well pre-9/11, so it was a little easier to do this then, but I was desperate sitting in front of the terminal, minutes away from where I'd had to park. I'd have missed the flight, had to get on that flight, big important thing in North Dakota. A fellow was walking past. I jumped out of my car, and I said, "Hey, would you park my car?" He gave me a very funny look, as they do out here. I said, $20. Park my car for $20. He kind of pretended he didn't even hear me at that point. $40. Park my car for $40. Well, $40, he kind of turns around, comes, and I give him $40 and my keys and say, "Park my car." I run and jump on the airplane. Now, the plane to North Dakota sets down in Minneapolis, so I run to the phone, call my office. "Please go to the airport, see if I have a car." But the report came back. The car was just where I had asked it to be parked. The keys were under the floor mat, everything perfect. And it's left me with this conclusion, which will maybe guide us in the health reform debates going forward. Even in Washington, D.C., people will do the right thing. It'll just cost you a hell of a lot more money. Thank you. Thank you very much.